Okay, so now for congenital infections, part 3. I'm Sarah, second-year fellow, continuing our in-depth tour of congenital infections. Attempting to continue on. My slide not advancing. There we go. So yes, so thus far we've covered toxo, syphilis, malaria, parvo, varicella. Today I had ambitiously thought we'd be able to cover both Zika and rubella, but it's just going to be Zika. So Zika virus. Zika is a positive sense RNA flavivirus. It is transmitted by the Aedes mosquito. That's the primary form of transmission. However, there can also be sexual transmission, congenital transmission, blood transfusion transmission as well, and it targets the neural progenitor cells. But here you can see study showing the presence of the Zika virus RNA in the plasma, whole blood, urine, saliva, and that it is maintained in semen over time. It's also been found in breast milk, cerebrospinal fluids, saliva, semen, and even tears. But as I said before, the main form of transmission is by the Aedes mosquito. On the graph and the map on the left, you can see the distribution of the Aedes mosquitoes across the world, so found pretty much globally. And then on the right, you can see where Aedes is found within the United States, and it is found here in Philadelphia. And in the middle, you can see a picture of the Aedes mosquito. So it can be a problem here. And then with regards to the sexual transmission, this is something that the CDC spends a lot of time discussing on their website. It can be sexually transmitted from a partner to a woman, even if her partner is asymptomatic. The figure on the right is a diagram from a famous study that first demonstrated the sexual transmission of Zika virus. We see the man had the onset of illness. The woman was in France and not exposed to Zika from insects. There was sexual intercourse, and then several days following the sexual intercourse, the woman developed these symptoms of Zika and turned seropositive and PCR positive. So as a result, the CDC recommends that pregnant women with a sex partner who has lived in or traveled to an area with Zika should use condoms during sex or abstain from sex during the duration of the pregnancy. They say that other couples in which partner has been in an area with risk of Zika can reduce the risk of transmission by using condoms or abstaining from sex. Healthcare providers should have a high index of suspicion for pregnant women with symptoms of Zika, even if they may have only been exposed through sexual contact. And we should test these patients accordingly. So for the epidemiology of Zika, outbreaks of Zika virus have occurred in Africa, Southeast Asia, the Pacific Islands, the Americas, and the Caribbean. The CDC keeps a wonderful website tracking where there are current outbreaks. Currently, there are no outbreaks right now. Purple shows areas where there have been reported Zika cases, past or current. Light purple is areas that are unlikely. Yellow is areas that have the mosquito, but no reported cases of Zika, and green is no need to worry about Zika. So Zika's got an interesting history. The first documentation of Zika ever was from 1947 when it was isolated from a rhesus monkey in the Ugandan Zika forest. This was back in the days when they named viruses based off of where they were first isolated. In 1952, the first human cases were documented in Uganda and Tanzania. And then we really didn't hear too much about Zika. It was one of those things that ID docs nerded out about, but no one else thought of. Then in 2007, we had our first real Zika outbreak. This occurred in the islands of Yap in Micronesia. Islands of Yap, it's inordinately fun to say. And they found that more than 70% of the population there was infected. This was also when they first started seeing identification with things other than just flu-like symptoms. They saw a correlation with Guillain-Barré syndrome in individuals who were infected with Zika at that point. Then in 2014, it made it to the Western Hemisphere, and the first outbreak was identified on Easter Island. And then 2015 is really when it made its big debut on the international scene with the outbreak in Brazil. and the identification of the association with microcephaly. Then in 2016, we had our first cases in the US. And here's just another way of looking at it, where we really don't see much about Zika until that first identification in 2007 in the Yap Islands. Then we see an outbreak in French Polynesia in 2014. And then we see a huge spike and a lot of interest from the WHO, CDC, and the international community in 2015, 2016, when the outbreak happens in Brazil. And it was really kind of a perfect storm there, where we had a completely naive population with a virus that had also undergone some mutations that made it more likely to have increased transmission. And then as quickly as it appeared, Zika kind of disappeared from the international scene as well. But it is still out there and it could come back. But there's some interesting epidemiology that was done, because it takes some great clinicians to be able to identify that we're seeing these increases in cases of microcephaly, and we're also seeing these increases in cases of Zika. So this is one of the first reports looking at this. This is Morbidity and Mortality Weekly report, where they saw an increased prevalence of microcephaly in infants born to women with confirmed Zika virus transmission in Brazil in 2015. So they looked at the various regions of Brazil, and they looked at the incidence of microcephaly before and after the outbreak of Zika. And they see that there's a dramatic increase in the rise of microcephaly following the outbreak. And this is across multiple states within Brazil.
Defined as 3 standard deviations.
Spoilers.
Sorry.
So there has not been consistent case definitions of microcephaly. So here they're just using like reported microcephaly. Hi, everyone. Then there were some nice basic science studies in which they were able to isolate the Zika virus from brain tissue. And here you can see some electron micrographs where they see the virus replicating in brain tissue of an affected fetus that had the microcephaly syndrome. But really one of the big things, one of the big challenges is saying, like, we see microcephaly, we see Zika. Is Zika actually a teratogen that is causing microcephaly? And this is a big debate in the field for a while. This is a nice work from Sonia Rasmussen, kind of looking at the criteria for proof of teratogenicity and then applying it to Zika. So the first criterion for proof of teratogenicity is proven exposure to the agent 1 or more critical times during prenatal development. And she argues that that criterion was met with Zika. A second criterion is consistent findings by multiple high quality epidemiological studies, controlling for confounders of the association. And she argues that they partially met this criterion. Third criterion for teratogenicity, careful delineation of clinical cases and a specific defect or syndrome. And here we have a very clearly defined congenital Zika syndrome meeting that criterion. Fourth criterion is rare environmental exposure that's associated with the defect. And here we're saying that the environmental exposure is the Zika virus, and it does meet that criterion. Back in the day, there was a lot of argument on this point. People were saying, oh no, it's not Zika, it's the permethrin or the DEET or the insecticide sprays that are being used because of the Zika outbreak. There was some nice epidemiological evidence that showed that it wasn't actually the exposure to the insecticides, but to the virus itself that was associated with the congenital Zika syndrome. Then our fifth criterion is teratogenicity in experimental animals. And they say this one's not a requirement for meeting the criteria for teratogenicity. At this point, they had not yet met that criterion, although subsequent studies that will show did meet this criterion as well. And then that the association should make biological sense, which it did for Zika. We know that the virus has a neural tropism. We're isolating it from the brain tissue of these fetuses, and we're seeing neurological defects as a result of the infection. And then finally, proof in an experimental system that the agent acts in an unaltered state, which has not been. So that was the Shepherd's criteria. Another criterion that, another set of criteria that are used for teratogenicity would be Bradford Hill criteria. And Rasmussen argues that these criteria are also met. So you want to see a strong association, a consistent association, a specific association. You want to see temporality between the exposure and the outcome. Not meet the biological gradient. Again, the plausibility, which we see, coherence, which we see. At this point, there was not yet an experimental model for Zika, congenital Zika. And then you want to see analogy with other similar viruses, which they argue we do see because of the other floppy viruses. So here are some of the early studies that helped to set up the association between Zika and teratogenicity. This was a study from Rio de Janeiro in which they enrolled pregnant women who developed a rash within the previous 5 days and then tested positive for Zika via PCR. They followed the women prospectively, and they saw 117 live-born infants born to 116 Zika positive women, and 42% had abnormal clinical or brain imaging or both, and there were 4 cases of microcephaly. So this is some of the first data that really was arguing for the causative effect of Zika on microcephaly. And they looked across all trimesters, and they saw that Zika infection across all trimesters was associated with abnormal outcomes. They also looked at the infant outcomes, measuring the head circumference, and they saw that there were cerebral calcifications, cerebral atrophy, ventricular enlargement, and hypoplasia of the cerebral structures. They saw this as late as infection at 34 weeks of gestation. And then they did see parenchymal brain hemorrhages in some of the infants who were infected as recently as 39 weeks of gestation. And then 63% had grossly abnormal results on neuroexam. So there were long-term effects of infection. And that included hypertonicity, clonus, hyperreflexia, abnormal movements, spasticity, contractures, and seizures. On the left, you can see the head circumferences of the infants. The red dots are Zika exposed, the blue dots are Zika unexposed. And you see that we tend to have more of the small head circumferences in the Zika exposed ones. They also looked at birth weight, and we see the same sort of trend. And then on the right-hand side, they break it down by the trimester of the infection, with the squares being first trimester, circles being second trimester, and triangles being third trimester. And we see that there's not really a huge correlation between trimester of infection and decreased parietal diameter. And you can see the 4 individuals who had met criteria for microcephaly since they're falling way off of those curves. And then another study looked specifically at the association between Zika and microcephaly. So here they compared cases and controls. The cases were neonates who were born with microcephaly, which they define in this study as 2 standard deviations below the mean. And then they tested the serum of the cases and the controls, as well as the cerebrospinal fluid for Zika, doing PCR and IgM titers. And what they found was that the overall matched odds ratio was 73 for microcephaly after Zika virus infection, after adjusting for potential confounders. So this is one of the big studies that really helped to push the field to believe that indeed Zika was responsible for the microcephaly that we were seeing. So that was kind of how we got to the point of saying Zika is responsible for microcephaly. And something to bear in mind if you're ever in a clinical situation where you're seeing a large number of cases of an anomaly and you're trying to figure out what the causative agent might be. So then shifting kind of over to the clinical side with Zika. So first for the pregnant person, symptoms of Zika, oftentimes these individuals are completely asymptomatic. If they are symptomatic, the vast majority have mild flu-like symptoms, so fever, rash, arthralgias, conjunctivitis, malaise, headaches, so really non-specific symptoms. And then in rare cases, there can be Guillain-Barré syndrome, myelitis, or meningoencephalitis, but those are quite rare. And then here are clinical characteristics that were identified in some of those original studies characterizing Zika in pregnancy. The vast majority of them had rash, those flu-like symptoms, and conjunctival injection. The table on the left is from that study that I had previously mentioned. And then the table on the right was a prospective cohort of Zika positive and negative women. And again, a lot of non-specific symptoms. There's not any sort of pathognomonic sign of Zika. So you just really need to have a high clinical suspicion. For diagnosis, the CDC recommends that we start with verbal screening for risk of Zika. So if they've got a positive history of exposure, that would include current or recent residence in an area where there's mosquito-borne transmission of Zika, recent travel to an area where there's Zika, unprotected sexual contact with a person who resides in an area with Zika. Also would screen for a positive history of signs or symptoms of Zika in a person who is living in an endemic area or has traveled there. And that would include, as we talked about, so the rash, the arthralgias, conjunctivitis, and fever. So once you've done your verbal screening and they have screened positive verbally, then you follow up with laboratory diagnostic testing. So there's two different testing algorithms. So we'll first talk about testing algorithm for someone who screens positive for Zika symptoms. So you want to collect the specimens within 12 weeks of the symptom onset. After that point, you're likely to get false negative results. And then it's really important that you test for both Zika and dengue. The Aedes mosquitoes carry dengue as well, which has very similar symptoms to Zika. So in this particular algorithm, they say that you should do the PCR and serology on both blood and urine. More recently, the CDC has been saying not to do the IgM serology for Zika, just for dengue. We'll talk about that in a second. So then if they test positive for dengue by PCR, they've got dengue. If they test positive for Zika by PCR, then this would be an acute Zika infection. If they test negative for dengue and Zika on PCR, but have positive IgM, then you'd perform PRNTs, plaque production neutralization tests. These are not routinely done in our labs, like LabCorp request is something that would need to be sent out to the CDC. And that will help to identify if you have a case of Zika or dengue or another virus. And then if it's negative for all of these things, then that would not be evidence of dengue or Zika. So that's our symptomatic individual, but what about our asymptomatic individual who's screened positive for a risk of Zika? So for these individuals, if they are asymptomatic with a recent exposure, but without ongoing exposure, the CDC says we should not do routine testing, but we can consider it based off of kind of shared decision-making with the patients. And I think this is kind of getting to a lot of our baby mooners who come back incredibly anxious. Otherwise, if they're asymptomatic with ongoing exposure to Zika, so if you've got a woman who's living in an endemic region in, say, Brazil, then you would test them 3 times during the course of pregnancy, first at the initiation of prenatal care. You should do the PCR test on both serum and urine. If it's positive, that would be an indication of acute Zika infection. If it's negative, then that would be evidence that they don't have an acute Zika infection.
So we should still be like guiding patients to go to like America or
I guide them to the CDC website and I tell them that they update it frequently on travel advisory for pregnant women.
Yeah, that's what I would say as well. And the CDC, I'll include like all their information on the last slide, but they're really, it's constantly changing. They keep it up to date. And their recommendations are also changing frequently and up to date. But as with most things, it's not that simple. It's complicated. This is why we love MFM. So why is Zika complicated? Well, first of all, the window for virus identification is pretty short. You really need to catch them within 2 weeks of that infection. So you could have someone who has congenital Zika syndrome that you find on an ultrasound and they're negative on the PCR. And that doesn't mean that they don't have congenital Zika syndrome. It just means you didn't test them in the window where it's going to come back positive. Other complication, there had been that big Zika outbreak, but now it's less common. With lower prevalence, there's an increased risk of your test result giving you a false positive. Which brings us to the whole issue of the IgM antibodies. So we know that IgM antibodies can persist for months to years following an infection. So if they test positive for IgM, they might not have had an infection at any point during this pregnancy. It might be there from years ago. There's also a lot of cross-reactivity. IgM has the 5 branches off. It's super sticky. It is not that specific. It's your first line of defense. It's grabbing onto everything. So if you have IgM from something like dengue or another flavivirus, you can get a false positive result from the IgM for Zika. So based off of that, the most recent CDC guidelines say don't do IgM testing for Zika, period. But this is a recent change. Previously, they were recommending it. And then if you did do an IgM result and it comes back positive, you can do a plaque reduction neutralization assay to help reduce the likelihood of it being a false positive. So this is basically looking at IgM titers, but not something that is routinely done by labs, and it would be a referral out to the CDC. And by the time you're doing that, you're probably on a first name basis with a CDC agent.
And the patient's delivered, we get to.
Probably. Okay, so now shifting gears to congenital Zika, the reason this is part of our fetal therapy. So there's nice data now of the pathophysiology of congenital Zika. There are both mouse and primate models. So here's data from a Nature paper with one of the first mouse models. And what they're able to show is that mice that are infected prenatally with Zika virus, in figure A, we can see that there is growth restriction of the Zika virus exposed fetus. In figure B, we can see that this is across the board with lower weight in those fetuses, and that this also carries over in smaller head size. And then when they dissected the mouse fetuses, they see that there is a tropism for neural tissue with high levels of the Zika RNA in the brain tissue. Here we can see it on immunohistochemistry as well, that there's a lot of virus in the brain tissue. They also saw that there was decreased cortical thickness in the brains of the mice, showing that the virus is causing the brain damage that we associate with congenital Zika syndrome. And they also saw ocular abnormalities and then increased markers of cell death in the brain. So mouse model confirms the pathophysiology of Zika. Then we get to our non-human primate model, some nice work out of University of Washington. And here they show that in non-human primates, we see that there is brain injury. We see that there is decreased head circumference by parietal diameter. We see tropism for the Zika virus for fetal brain tissue, as well as the placenta. And we see damage to the brain with gliatic white matter present. So then switching gears to the humans, because that's who we treat after all. We know that vertical transmission can occur in any trimester of pregnancy, and there's about a 65% transmission rate. So from the study from Rio de Janeiro, of the 130 infants born to PCR positive mothers, 65% were positive by at least one assay for Zika virus. And this included PCR and IgM from urine and serum. Then we know that transmission can occur whether or not mom is symptomatic, and there doesn't really seem to be a correlation between the degree of maternal symptoms and likelihood of Zika virus transmission. And then we know that not all vertical transmission or congenital infection will result in congenital Zika syndrome. So in children who had an amniocentesis done, it was about similar rates of those who had abnormal findings and normal findings among those who were PCR positive. That said, earlier maternal infection is associated with increased likelihood of having congenital infection, but not of having congenital Zika syndrome. And then this is just going back to that initial study that we talked about earlier on. where we do see infection occurring across all trimesters of pregnancy. We do see adverse outcomes occurring across all trimesters of pregnancy, and there does not seem to be a real strong association here, which is in contrast to a bunch of other congenital infections where there is a large influence of the timing of infection on neonatal outcomes.
So there's no association with like severity and timing, but no association with transmission.
So more likely to have transmission earlier, but there does not seem to be an association between congenital Zika syndrome and timing of infection. And here was another study looking at adverse outcomes over time. This was a prospective study of women who had PCR confirmed Zika. And we see similar things where across all of the trimesters, there is risk of adverse outcomes. And there really doesn't seem to be a strong correlation with timing of infection and the type or severity of adverse outcome. And the adverse outcomes that we see include neurological and ocular defects, microcephaly, intracranial calcifications, ventriculomegaly, lissencephaly, neural tube defects, eye abnormalities. Which brings us to congenital Zika syndrome. So the classic congenital Zika syndrome is microcephaly, ventriculomegaly, and intracranial calcifications. But with all of it, as with all of these things, you're not necessarily going to have all of those. You might have one, you might not have any. So from a systematic review in 2016, there were about 22% of congenital Zika syndrome had microcephaly, about 33% had ventriculomegaly, and about 27% had intracranial calcifications. On the right here, we've got a more recent study from the Radiology Society's guidelines. And again, we see kind of those same sort of anomalies. So lissencephaly, pachygyria, changes to cell sign or GRI, abnormalities in the corpus callosum, ventriculomegaly, cerebellum abnormalities, vermis hypoplasia, brainstem abnormalities. So really lots of things can go wrong in the nervous system and tend to be associated with Zika.
So just, I know the genetic counseling students are here. So basically, not every fetal malformation you see by ultrasound on a baby, it's basically a genetic or syndromic or non-genetic. So it can also be an infectious reason of why a baby can have congenital malformations. And this is a huge lesson that we're learning today from Dr. Boudova. Thanks.
Thank you. And then here are just some more pictures of abnormalities that you can see with congenital Zika syndrome. So in the ultrasound findings on the top, we see calcifications, increased pericerebral spaces, ventriculomegaly, abnormalities with the corpus callosum. The next line down, we see MRIs, which helps to further delineate those abnormalities. And then further down, we actually see the birth outcomes of the children with congenital Zika syndrome. And then more pictures of congenital Zika syndrome findings on ultrasound. So we see calcifications, we see dilated ventricles, we see placental calcifications, and then in the this particular case was an autopsy. There's loss of gyrations, wide sylvian fissures, and dilated lateral ventricles on the postmortem. So wide range of manifestations of congenital Zika syndrome, from asymptomatic to mild neurological symptoms to the full-blown congenital Zika syndrome. Clinical findings include microcephaly, which can be proportionate or disproportionate to the size of the fetus overall. And then interestingly, sometimes it doesn't even manifest until up to a year after birth. They can get hydrocephalus, which will keep their brain size normal on ultrasound, but then after delivery, the hydrocephalus goes down and the microcephaly presents. And then the microcephaly, it's been estimated there's about 1 to 5% risk of microcephaly occurring following Zika exposure.
I had a baby in 2016 and I was measuring her head circumference every day of postpartum. That's the chokehold this had on us in those days.
Yeah, and there are still great YouTube videos on how to measure baby head circumferences all over the CDC website. In addition to the microcephaly, you can also see craniofacial dysmorphism, neuromotor abnormalities, seizures, arthrogryposis, club foot, ocular abnormalities, hearing loss, cardiac abnormalities, other CNS abnormalities, growth restriction, high drops, and preterm birth as well. Which brings us to Carrie's question of what is microcephaly? I've been throwing that term around, and it's one of those things where you think there's a nice clear definition and then you start digging into it and it really gets complicated.
I didn't say what is, because I feel like I know what is. I feel like a lot of.
That's one of us.
I know, I mean, we use 3 standard deviations, no? No?
Depends on who you ask. If you ask the WHO, you use 2 standard deviations or less than the 3rd percentile. If you ask the CDC, 2 standard deviations or less than 3rd percentile. If you ask SMFM, head circumference, 3 standard deviations. And then it's definitely pathologic if it's more than 5 standard deviations. So for our group's purposes, we use 3, although even if you look in Woodward will say things like 2. So
Wait, just to clarify, are these all talking about an estimated head circumference in utero, or is it for once the child is born, adjusted for gestational age?
So except for the
because that's
ones
2
that
different
offer
things.
is postnatal.
yeah, I believe these are
Because
postnatal
SMFM,
for
I think, was
CDC and
talking
WHO.
about,
Good point.
SMFM was specific to a fetal antenatal.
Yeah.
Okay.
Good catch.
And I think, and basically the point being that, ultrasound is for everything a screening and not a diagnostic tool. And as a screening tool, it has greater or less accuracy depending on what the, diagnosis is related to it. And so SMFM was looking at what is the threshold of an estimated in utero head circumference and the, ability to predict true microcephaly postnatally. Whereas I'm not sure if these WHO and CDCs are talking about a postnatal diagnosis of microcephaly, which is based on the actual measured head circumference of the baby.
This slide seems to focus on postnatal, but SMFM on prenatal. So maybe they left it to SMFM, which makes sense.
But I will say a lot of the research studies would use the 2 standard deviation definitions for,
For postnatal, really.
right, but they would be using that with the ultrasound findings,
Okay.
Well, interesting.
which I think might be just to increase their sample size, but. So just something to be aware of when looking at studies with like. So then just kind of a nice picture stolen from a review of kind of summarizing a lot of the clinical stuff. So multiple modes of infection for Zika, most commonly from mosquito, but can also be sexual, blood transfusion, or congenital. The vast majority of maternal cases will be asymptomatic. Those that are symptomatic will be mild. It's rare to have complications. That's less than 1%, but those complications do include Guillain-Barré, myelitis, polyneuritis, meningoencephalitis, ocular findings, thrombocytopenic purpura, myocarditis, and very, very rare to have maternal mortality from it. Then for the pregnant woman, about 20 to 30% of fetuses and neonates will be infected, and low rates of fetal loss, 5 to 14% congenital Zika syndrome with microcephaly, 5 to 14% congenital Zika syndrome with 4 to 6% microcephaly. And then a large number will be asymptomatic or uninfected. So how do we diagnose congenital Zika? It can be done with amniocentesis or placental biopsy PCR, or after the baby's born, you can do CSF PCR. For managing Zika during pregnancy for the mom, it's really just symptom management. There's no treatment. So really just giving fluids and Tylenol. Important thing is to avoid aspirin and NSAIDs in these women. Usually avoid NSAIDs anyhow, but try to avoid the aspirin until you've ruled out dengue, since there's a lot of overlap in the symptoms and epidemiology of dengue. And dengue, if you give aspirin, there's a risk of hemorrhage. So, we are MFMs, we do ultrasounds. This is how we manage our patients. So for ultrasound for Zika, it's a little bit frustrating. Like there's not great sensitivity or specificity for ultrasound findings for Zika. From a systematic review, they saw that a high proportion of microcephaly was confirmed postnatally. And it was about 78% that were confirmed, and that's the top figure here. And that among 190 fetuses without the congenital Zika syndrome, about 17% had, among those that weren't identified on ultrasound, 17% had congenital Zika syndrome postnatally. There's also been a prospective study from Brazil, that was a more recent one, and that looked at PCR confirmed Zika. And from this, they saw that 49% sensitivity and a 68% specificity for ultrasound findings for congenital Zika syndrome. And then when they limited it to only Zika-associated abnormal prenatal ultrasound findings, the sensitivity fell to only 22% and specificity increased to 98%. Ideally, an ultrasound should be done within 4 weeks after the Zika exposure, and then serial ultrasounds should be done every 4 weeks after that. And then there's some thought that MRI may be more sensitive or specific for brain findings if you have uncertainties based off of your ultrasound. So what ISWAG recommends for Zika is for starting with an accurate estimation of gestational age. They point out that this is really important so that you can know if your head circumference and biparietal diameter really are sorry, wasn't sure if that was to me. And then you'll want a good baseline ultrasound scan, including the anatomy measurements of lateral ventricles and transcerebellar diameter. You'll scan every 4 to 6 weeks. And then if you see any sort of deviations from normal, they recommend using a head circumference of 2 standard deviations below the expected mean for gestational age to refer to a specialist. And then most of the individuals where the head circumference is 2 standard deviations below the mean would be expected to be normal. And so they recommend doing serial follow-up. So then in the cases where the head circumference is 3 standard deviations below the mean, or where there are extensive anomalies, they recommend considering an amniocentesis for Zika and an MRI. Then postnatally, they recommend doing standardized head circumference measurements and doing laboratory confirmation where possible from the placenta. So on the ultrasound, what we're looking for, things like an irregular head shape, particularly a slanting or sloping forehead on your junior profile. You're looking for ventriculomegaly, parenchymal calcifications, cystic lesions, callosal dysgenesis or agenesis, cerebellar hyperplasia or Vermean dysgenesis, enlarged cisterna magna, abnormal cortical development with reduced amounts of brain parenchyma or increased cerebrospinal fluid, arthrogryposis, clubfoot, or microophthalmia.
So basically it's, can you go back? So basically it's in the differential diagnosis also of Dandy Walker. You know, so basically, but seriously, like almost most of the central nervous system problems. So we include the ventricles, the calcifications. This is different than CMV. How are the CMV for the senior fellows or Keely and Sarah different between Zika and CMV calcifications?
Periventricular.
Yeah, so they are multiventricular. The ones with Zika, you can see them within the parenchyma anteriorly. And then different forms of corpus callosum problems. Posterior fossa, always remember, can be a problem. So the differential diagnosis for Dandy Walker, as we mentioned, and then the different cortical problems. And because of that, you can have the joint issues. So the baby is not going to move. So these babies are going to have arthrogryposis. This is always an easy way for you to remember, like, why is the baby having a joint abnormalities? Does affect the eyes, affects the hearings. So
Yeah. So the other thing we do is MFMs all the time, amnios. So amniocentesis for Zika. So a positive PCR is diagnostic of an acute congenital infection, but not necessarily of congenital Zika syndrome. And then a negative PCR does not exclude Zika because remember we were talking about earlier that window where you really have like 2 weeks in which to detect it. So what they've found in studies is that structural abnormalities were identified pretty much equally in those with and without Zika detected based off of the amniocentesis. And then they recommend that amnio should be done about 6 weeks after exposure, but not before 21 weeks gestation. And then the sensitivity and specificity of the amniocentesis really is not known.
So there's no treatment. A positive test doesn't predict outcome. A negative test doesn't predict outcome. But we should test everybody that has exposure.
We should offer.
Not recommended, right, but offer. Recommended to offer.
Cui bono, who benefits?
Yeah.
You should be on these committees.
What? What? I'm serious.
I mean, I would argue that the benefit of amniocentesis in these cases might be if you are concerned for other things that you can more accurately diagnose with amniocentesis.
Sure.
So if we see all these brain findings, it might be good to have the amniocentesis in order to get the genetics, to rule out other infectious causes. And if you're already doing the amnio, consider throwing in a Zika. Because if it's positive for Zika, then you know that you've got Zika. Now, whether or not the Zika is responsible for your abnormal findings is another issue, but so that would be my argument in favor of, you know, but I.
Yeah, do a lot of
hear your
other-
point.
Yeah, I agree with Rhea.
So yeah, and then here's just a case series of a number of patients who had amniocentesis done. And they looked at the timing of symptoms in the mom, the timing of the amniocentesis, whether it came back positive. And for a couple of these patients, they actually did serial amniocentesis, and you can see that while initially positive, it eventually turned to negative. Really calling into like really showing the importance of the timing of the amniocentesis with regards to the symptoms.
How do they recruit people for serial amnios?
No, I'm gonna be honest with you, you know, when this happened, Vincenzo, was it 2015 or 2016?
Yeah,
2016,
well,
2017,
in the
really
US.
here, big, yeah.
Yeah, but we were at MFM and Laura Aili was the president. She called for an emergency meeting. We were somewhere, maybe Vegas or something.
I remember.
Wanted all the members to come in and she talked about this and we all freaked out because it was just starting and we didn't know what to expect. People are gonna die. So it was a big deal. And then, you know, you had all the people from South America who came and presented things at the NICHD. They had a big 3-day conference about Zika and congenital infections. So it was a huge deal. And I think that's why probably there were so many unknowns then, you know, so.
I remember the time very well.
Yeah,
Lots of pictures of
It was
mosquitoes.
like yesterday.
I mean, I'm looking at the CDC map and stuff, and there are no red areas, of current outbreak.
No current outbreaks.
But then the next one in purple here are countries that have ever had Zika, which include us and all of Central and South America, India, many African countries. And I think there was a case in France or a few cases in France, so France is still. But you're not gonna go to Paris, like, you know what I mean?
So then in terms of more,
It's hard, like, this is a virus you cannot treat. And.
Yeah.
Well, you finish up, maybe you
I
can.
think here was the. That's the map that you were referencing.
Right, yeah, that's kind of what I was looking at, right? And so on one side, you cannot treat it, which is funny because, COVID and HIV, we found, for many viruses now, we found some approaches. So have you heard of any? I think it's probably too uncommon to, not cost
I mean, there's
effective.
really not any treatments for the flaviviruses.
Any of them, dengue.
Okay,
So you can only prevent it, so you don't travel to the country, but right now, I'm not sure this country really you wouldn't travel. I guess you could nets, I guess, would be preventive.
Yeah, I mean, the thing with Aedes though is it bites during the daytime. So if you're trying to avoid malaria, sleep under bed net, because those are evening, that's Anopheles, which bites at night. But Aedes is a daytime mosquito, so really just really the thing is avoiding the mosquito bites by wearing long sleeves, wearing DEET, permethrin infused clothing. And those are all recommended and safe for use during pregnancy.
I love this slide. That's
Yeah,
great.
another
Sarah,
thing
I had a
is that
question. Oh,
fumigation from the health department is very important because Aedes aegypti is coming to United States as well. I just got in the news that because of dengue, they're fumigating in Florida, Texas, Alabama,
wow.
Louisiana. So they have cases with Aedes aegypti, and it's in a rainy water, so it's very complicated with this season. So just fumigation is the most important part of this with this mosquito.
Back to management. So there is an increased risk of stillbirth with Zika. So you can consider NSTs or BPPs, but there's no guidelines on timing or frequency of antenatal testing. Likewise with UA Dopplers, because growth restriction is more common, you would likely be needing to do Dopplers for the growth restriction, but there's not any Zika specific Doppler recommendations. For labor and delivery, routine mode and timing of delivery, there's no contraindications to interaxial anesthesia, although the Anesthesia Society has published that there's a theoretical risk of iatrogenic viral crossing of the blood-brain barrier when an epidural is placed. But that said, they still are pro-epidural. And then you can send the placenta for pathology and possibly PCR on the placenta. The CDC will consider doing testing for Zika, dengue, chikungunya from frozen and fetal and placental tissue. If you are going to send something to the CDC, they've got very detailed instructions on exactly what sort of specimens they want, with at least 3 full thickness placental samples. And then breastfeeding, virus, as I said before, is found in the breast milk, but there's no evidence of any Zika transmission through the breast milk. And so the WHO, the CDC, and ACOG all strongly recommend breastfeeding even when mom has Zika. And then for future pregnancies, Zika infection in a prior pregnancy does not pose a risk of birth defects in a future pregnancy. And once a person has been infected with Zika, they are likely to be protected from Zika going forward. Which brings us to prevention. We are kind of already jumped over this. No treatment, no current vaccine, but there are phase 1 clinical trials right now of mRNA-based Zika vaccines. The phase 1 studies have shown good safety, with the most common issue just being injection site pain, as is common for pretty much any vaccine. So no local spread in the US of Zika since 2017, but that doesn't mean it couldn't return. And then I think the important thing for this and for all vector-borne disease is avoiding mosquito bites if you're in areas that have mosquitoes. And then reporting Zika is a notifiable condition, so you should report any cases to your state or local health department. They should report it to the CDC or ARBANET, and the CDC has very detailed contact information for how to reach them and talk to anyone about Zika anytime. But I think the important thing for this talk really is a lot of the principles of Zika can be applied to any future emerging infectious disease. If you're seeing like hotspots of fetal anomalies, consider whether or not there might be an infectious origin for it. And I think there's a lot of kind of public health lessons to be learned from the outbreak. And then just wanted to thank everyone for coverage while I was in Ghana. But I know that the pictures that you really want to be seeing from Ghana are these. Lots of fetal anomalies there. This is in 1 week, I saw 2 cases of severe fetal ventriculomegaly, and they said that that's the norm. Multiple cardiac anomalies, So I'm talking with one of the clinicians there, Dr. Dean, about seeing if they would like to present some of their cases at our meetings, since they get a lot of severe pathology. And then I'm working with Dr. Dean to try and, they don't have the funding to do amniocentesis for any of these anomalies. The patients have to pay out of pocket for amnios and it's prohibitively expensive. So we're going to be writing a grant to try and get some funding to get to the etiology of particularly the severe fetal ventriculomegaly.
So what do you think is going on? Why do we think they have more fetal central nervous system abnormalities like ventriculomegaly, or it just happened the week you were there?
No, they said that that was the norm. He said I was doing some searching on fetal ventriculomegaly and like there's a case study of, or a case series out of Ireland where they had like 95 cases over a 20-year period. And when I was talking to Dr. Dean about that, he was like, oh yeah, I can get you 95 cases in less than a year.
Sarah, what is the situation in Ghana about termination of pregnancy? Is there an option?
Viability is defined as 26 weeks, so they can terminate up to 26.
And does he think it's a genetic etiology or does he think it's infectious?
Yeah.
You two better
That's
live.
why we're gonna do the study. But they do.
Have a lot of work to do.
Yeah, I mean, I think there's probably a lot of CMV. There was definitely a lot of placental calcifications in the 2 cases that I saw. We don't know. I mean, there's also probably a little bit of consanguinity from people coming from the villages. There's probably more CMV there than here. Or who knows, maybe there is an unidentified emerging infectious disease and we'll need to follow in the same steps as the doctors who discovered that Zika caused microcephaly. And it comes full circle.
Or it can be also genetics. Great. So much work to be done, Sarah.
But all this is to say, thank you guys for covering for me, and I'm gonna try and get you some interesting cases from Ghana to review.
Thank you.
Sarah, I had a quick kind of general question. Is there something about, as when we think about viruses and congenital infections, are there characteristics inherent to a virus that make it more or less likely to cause a congenital infection? Thinking about when there are new outbreaks, are there specific virus types that we should be more concerned about looking for congenital impacts?
I think a lot of it would have to do with tropism. You'd want to make sure that it can have like hematogenous spread or tropism for placental tissue. But I think a lot of those things like you wouldn't know until you've already had the congenital infections and have started digging into that.
So the 2 big ones that probably the most common one would be CMV, right, Topsha?
Mhm.
It really depends on which trimester of pregnancy was the exposure to the baby. And the second big one, which is, early seen, but we have to study it a lot, is toxoplasma, which also Sarah did give us a lecture about. I think these would be the 2 big ones. Zika is no more now.
Parvo. I mean, it's not really teratogenic so much as,
Yeah.
It's gonna cause, the bone marrow thing.
I mean, you've got
Maybe some
varicella.
Varicella, but it's also very rare for it to cause, the contactions and the skin changes. So, but you need to study this for your boards too. So.
And the other thing I was wondering is for Zika specifically, I think it's interesting that the impact doesn't vary by trimester, which is, in contrast to what we usually see. Was there a hypothesis for that?
I didn't see anything. I also do wonder how much of this is just we don't have the same volume of cases for Zika as we do for things like CMV.
Got it. So
Um,
it's more that.
I wonder
we just
if we
power
had
to-
larger numbers, would we see more of a trimester specific impact? But
So something else to think about it when you have birth defects in another countries is fumigation or their crops products that they use. Sometimes they are not approved in the United States. I can tell you, like in Colombia, they fumigated with glyphosate to prevent cocaine crops. And after that, we have a lot of anencephaly and neurological birth defects.
I mean, that was the initial thought for the Zika outbreak, was they thought the microcephaly was caused by the insecticides.
Thank you.
So well done.
Great. Any questions?
See.
Any questions from the genetic counseling students or anyone who's on video? Otherwise, I need to discuss with you what happened with our